Hey, ubba-bubba, welcome to JuanMD. My name is Juan. I'm an MD, and on JuanMD, I talk all about living life as a doctor and making the most of my one life to live. So last time I did a stream, I was studying endocrinology, but my mic was having some feedback problems. And so today I'm going to be studying cardiology, and coincidentally, I'm going to be using a cardioid microphone. See what I did there? And it's Valentine's Day today, so it's like hearts galore. And yes, I'm going to be studying the heart, the circulation, everything to do with the heart today. I have to work on my schedule because lately I've been very uh nocturnal, if that's the right way to put it. More like daytime sleepiness, that thing. I don't think I have anything. It's just snoring, maybe, but I don't know. I really need to work on my schedule so that I can be regular with my studying. Uh, you know, wake up, study in the day, be effective, get a good night's sleep. That's very important to good studying, but I'll do what I can for now. So what I'm gonna do today is a bit different. I'm not gonna be using a timer today because I think the timer can get a bit distracting for me. So instead, what I'm gonna do is I'm just gonna read. I'm gonna set myself a goal. This chapter is roughly 54 pages long, more or less 54, 53 pages long. So today I'm going to make it a goal to read 25 pages. And then I'll do the next 25 the next time I study. Um, I don't know. I guess the time pressure is distracting in itself. So, rid the distractions while I'm studying. Speaking of which, I'm going to put this on silent. Silenzio your phone. And with that out of the way, um, highlighters, post-its, book, and I think I'm good. I'm going to study, and I'm going to update you guys every now and then, maybe when I'm done with the 25 pages. Let's see. Man. Let's see. Hmm. Okay, what's that? What's on this here? Hmm. Oh, of course. Hmm. Sorry. Okay. Sorry. Did that scare you guys? That is my reading for today. I read quite a lot about cardiology. A lot of it was about acute coronary syndrome and heart failure. Well, not heart failure yet, just managing acute coronary syndrome. Um, where can I start? So it's funny because this chapter on cardiology started out with discussion on syncope. Um, but usually syncope, which is fainting or loss of consciousness, is caused by uh, one of the major causes of syncope is heart problems, cardiac problems, cardiovascular problems. Usually, if the person's syncope happens right away, um, then it's caused by either a heart or brain problem. However, if it's a gradual thing, like it's a gradual loss of consciousness, it's caused by metabolic problems or maybe hypoxemia. Now, if it's a sudden loss of consciousness, but a gradual regain of consciousness, then it's most likely to be seizure induced, so neurologic. Unless it's an absence seizure, because absence seizures uh, are a weird kind of seizure and you can regain consciousness right away. Although I haven't read that part yet, but I know what an absence seizure is. Believe me, I know what an absence seizure is. An absence seizure is like when the person just staring into the abyss, and then she's suddenly like, "What? What just happened there?" Oh, that's an absence seizure or absence seizure. I don't know how you pronounce it actually. But if the person regains consciousness right away after losing consciousness, then you can be confident that it's a cardiac problem. However, there's also a thing that's called vasovagal syncope. This book doesn't explain what it is, but it's essentially fainting because you saw blood or you saw something scary. Then again, you'd have to distinguish that from Takotsubo cardiomyopathy, which is when a sudden release of epinephrine, norepinephrine, because of a really stressful event, causes your heart to stop beating, and it starts ballooning. Hence the word Takotsubo, which derives from the Japanese word for octopus trap. No, I didn't read about that yet here. Um, but where was I? Takotsubo, fainting. Right. Vasovagal syncope happens when you see something gross or something that creeps you out, and because of that, you faint. It's usually like in movies when um when someone delivers like really surprising news and one of the comic relief characters faints. Yeah, that's vasovagal syncope. And people who faint because of vasovagal syncope can regain consciousness right away. But anyway, okay, so the person faints and regains consciousness right away, and it's not because of vasovagal syncope, so it's probably a cardiac problem. So your first thing you're gonna do is you're gonna do an EKG, and then if the EKG shows an abnormality, then you can kind of determine where the problem is. So if it's an infarct in the left wall, in the anterior wall, lower wall, you can like V1, V2, V3, V4. Lower wall, by the way, is V1 and V2. Anterior wall is usually V2 to V4. Um, is that right? Do you do the EKG right away? Yes. Oh, no, 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 no. Cardiac exam first. I'm sorry. If you can determine that it's a cardiac problem, then you have to do cardiac physical exam, and then if the physical exam is normal, then you should do an EKG. If it's abnormal, then you should do an echocardiogram. Yes, 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 yes. I got that right. Okay. In addition to the EKG, well, you have to measure the CKMB or the troponin levels because usually with myocardial infarction, um, these are released from damaged heart tissue, and these chemicals are released into the bloodstream. Usually, one of the first to be released is troponin, it's released immediately. No. Myoglobin. It's released immediately, but then it can go away in like 2 days, 2 to 4 days. But troponin, you can wait for that. No. Not troponin, CKMB. You can wait for like 2 or 4 hours. Actually, both CKMB and troponin. They're released at 2 to 4 hours. Um, it's the CKMB that goes away first. Same time as, was that 2 to 4 hours or four? I think it's 4 to 6 hours. I'm getting the numbers confused. 4 to 6 hours. 4 to 6 hours. 4 to 6 hours. 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 Yes, 4 to 6 hours. The Yes, the myoglobin and the CKMB are going to go away at 1 to 2 days, but the troponin can take as far as 7 to 10 days to go away. However, the person gets a myocardial infarction, you do the whole treatment, the patient is discharged, but suddenly within the 7 to 10 day period, there's a sudden increase again of any of the molecules, then you probably have a new infarct, and he's gonna have to admitted again and do the whole procedure again. So that's hard. That's tough. Okay, so coronary artery disease is usually because of narrowing of the coronary arteries. Your heart is very dependent on oxygen and energy. And when the coronary arteries narrow, well, your heart's not gonna get any of that. And you're gonna that's usually because of blockage of the flow. You can't go with the flow, so the flow is a no, and your heart goes a go. That sucked, man. But yeah, that's the point. The most serious, I saw it, but I kind of knew it. The most serious risk factor for coronary artery disease is diabetes mellitus because it predisposes to increase in LDL. Also, hyperlipidemia is a risk factor. um, it can exist without diabetes in cases like what? Type 2 dyslipidemia. Because I know that one is associated with cardiac disease. Um, type 2 dyslipidemia. No. Type 3 was this beta lipoproteinemia. I remember that because of the bat. Um, type 2, no, type 1 was the koala with the apple juice. Type 2 is the lobster. Um, So there's like joint deposits. And type 2 has joint deposits, and you're predisposed to myocardial infarction. With APO2, no, APO2 is the koala. There's a mutation there. I forget, but it's in one of my videos. I'm gonna post the link to that video in the comments below. You can check it out if you want to. Okay. Right. There's also a family history of premature coronary artery disease. Oh, I forgot to mention hypertension. It's the most common cause for coronary artery disease. Not the most serious, but the most common. Um, and then finally, yeah, family history of a first degree relative with premature coronary artery disease. A first degree relative is either, oh, hi, I have a new, uh, hi, Dania. Nice to have you. Thank you for coming to join us. Thank you for coming to join. And I appreciate the appreciation. Smile. Yeah, I like to summarize what I'm doing after the session, because they say that when you're able to teach, when you're able to like what you just studied, it's most retained in your memory if you can teach it well, if you can communicate it in a way that you understand. I would like to do that with art. I really would like to do that with art, but the thing about art is it takes up so much time. Um, so I just prefer to just, I guess with these videos, with the live stream format, it's easier for me to do the live lecture thing. after studying it. So yeah, where was I? Hypertension is the most common risk factor. Thank you, Danya. Um, glad to have you with us. There's also a family history of premature coronary artery disease. Premature coronary artery disease is defined as an onset at less than 55 years of age in a male or 65 years of age in a female. And this is a first degree relative, not your grandpa, not your aunt, not your second cousin twice removed, first degree relative. So that's the parents, the siblings, or the children. Well, the book said just parents and siblings, but it's not impossible to have your kid get a myocardial infarction. So technically, no, get a coronary artery disease. So technically, a kid would still be a first degree relative. It would be sad, but it's something to consider, right? Tobacco smoking is actually one of the most important risk factors for coronary artery disease, and it's one of the most crucial parts of management. By stopping smoking, you actually reduce your risk of coronary artery disease by 50% in the first year and 90% in the second year. So it's that smoking is that bad for you. So in a nutshell, don't smoke. Also, if your age is greater than 45, if you're a man, and your age is greater than 55, if you're a woman. Now, the problem is, well, not the problem. It's not really a problem. I guess it's a problem for the med student because you have to remember all this stuff. But especially if you're a woman, this is really good for you because you have like a protective um, menstruation is actually protective against coronary artery disease. Once you stop menstruating, then you become more prone to it because your risk kind of becomes similar to uh, the risk factors of a male. There's a question in the comments. Can red meat make your risk of coronary artery disease worse? Well, okay, I didn't read red meat in this chapter. I'm gonna probably come across it in the liver chapter. But the thing about red meat, um, I can't answer for sure. But especially if it has a lot of preservatives, there's stuff. No, red meat doesn't have preservatives. It's just red. It's just, let's see if there are any risk factors associated with red meat. I know red meat is really high in iron, but iron is like too much of that is not good for your liver either. So what is the risk of red meat? Let's see. Red meat. See, the thing about doctors is that they don't know everything, so we have to go back to studying. That's why I'm studying. That's why other doctors should be studying. A doctor who claims to know everything, well, it's harder to trust a doctor who claims to know everything. But if a doctor is able to admit that he doesn't know everything, then you can trust that doctor more because at least he's honest with you, you know? We have to be honest with ourselves. We keep on learning. Learning is a process. You don't, wake up one day and like, I know everything. No, that never happens. You have to keep on learning. Red meat. Red meat. Huh. Okay. This book doesn't mention red meat, so I will have to get back to you. But thank you for the question. Thank you for the question. I do not think red meat is associated with coronary disease, but I will have to look up whether it is a risk factor for other diseases. Danya says that it might elevate blood pressure. Let's actually, you know what? I could look it up right now. I have Amboss, but the thing is, I'm not allowed. I can't like live stream that to you guys because of like copyright reasons. But Amboss is a really comprehensive source also on this stuff. Actually, I'm up to date on my phone. My computer's a bit slow right now because of the stream, so I can't do other things that much. Let's see. Okay, red meat increases your risk of colorectal cancer. Okay, let's see. This one was updated. Wait, let me see if I read that correctly. There's always Google. Yeah, I can't use Google right now on my computer because it's slow because of the stream. Yes, colorectal cancer. Red meat is associated with colorectal cancer, but I can't find an article that would. Oh, by the way, I have to cite my source. My source is NHS. Okay, that's according to NHS. Also up to date. Says although they don't really cite their source in the correct format, I guess I can't find it here. But those are my sources for this one. Let's see if red meat's associated with other things. Yeah, it's associated with cancer, colorectal cancer, but I can't find any relation to heart disease. If you find an article, I would like to see it in the comments. So uh leave it in the comments, and I would be glad to read up on it. Thank you so much for your question. Appreciate it. Okay, where was I? Yes. Okay, let's go back to the risk factors of cardiac disease. First, there's diabetes mellitus. Yeah. So after a 10-year history, but particularly of diabetes mellitus, you're prone to developing coronary artery disease. Yeah, like I said earlier, hypertension is more common than diabetes. And actually, 50% of people with hypertension don't realize that they have hypertension. Also, yeah, I explained the whole family history thing. So it has to be a first-degree relative with premature coronary artery disease. Okay. With regard to coronary artery disease, when you're looking at hyperlipidemia, typically what's most dangerous is the levels of low-density lipoprotein. High-density lipoprotein is your good fat. Low-density lipoprotein is your bad fat. Particularly when it's in your system, you have to have high levels of HDL and relatively low levels of LDL. When your LDL is high, particularly you're particularly prone to developing coronary artery disease. That's why you give statins like atorvastatin. How do you pronounce that? I still, you know what? I keep on reading up on that, but I keep forgetting how to pronounce it. I'll just say atorvastatin. Atorvastatin. That sounds right. Atorvastatin or other similar meds are given to people with coronary artery disease, and the goal in particular is to decrease LDL levels to less than 70. That's your goal. It's beneficial to these patients. You can try to increase HDL. You can try to lower triglyceride, but the benefit of these on the long term is negligible compared to the use of statins in decreasing LDL. Okay, what's next? Oh yeah, I mentioned the Takotsubo cardiomyopathy earlier. Hmm. All right. You have to manage this with beta blockers and ACE inhibitors. Yeah, and I mentioned smoking. You have to correct that. It'll develop the greatest benefit for patients with these risk factors. And then the chest pain that you usually get from cardiac disease, it's usually dull or heavy, not like electric. Electric, you would associate that with other diseases. It's not pleuritic, meaning it changes with your breathing. It's probably a lung problem if you have chest pain associated with breathing. And then it's not associated with tenderness, like when you push it, it hurts. It's probably costochondritis if it's associated with tenderness. And then finally, it's not associated with a change in position. Change in position, what medical condition would you consider with a change in position? That would be, okay, it didn't explain what, but as long as there's a change in the pain sensation when the person like goes to his side or lies on his back, then it's probably not a heart problem. Okay. I remember reading an article before, it wasn't here, but when women in particular have heart disease, it's usually misdiagnosed. Like what this book says is that usually if it's associated with gastrointestinal problems, then it's not going to present this way. But the thing is, sometimes uh, women can have pain here in the epigastric area, or they can have pain in other parts of the body, in the abdominal area, and it's actually cardiac disease. Now, I don't want to confuse you if you're studying for step 2. I shouldn't confuse myself too. But I guess that merits like further study because like we have different anatomies. And so it's worth looking into so that we can take care of our patients better, you know. Okay, tenderness is associated with costochondritis. That's when the muscle position, the muscle strain, is what causes the chest pain. When it radiates to the back, and when there's like unequal blood pressure in your left and your right arm, then you can consider aortic dissection. You can check that out with imaging, like X-rays. Like there's gonna be a wider mediastinum in the X-ray, or you can also check CT or MRI. And there's also pericarditis. Ah, there we go. Pain that changes with lying down. Pericarditis is when there's inflammation in the tissue that's surrounding your heart. And so, when you do an echocardiogram, an EKG on these patients, there's going to be a CT, ST elevation everywhere, like diffuse ST elevation, and then you're not going to see the PR. I was told before that it looks like a PR depression, but really it's just displaced by the ST, so it looks like a depression, but the PR is still there. I'm not sure if that lecture was accurate, but that's what I remember. But according to this, it says there's ST elevation everywhere, and then there's PR depression. And then if there's epigastric discomfort, and then it's relieved by eating, you have a duodenal ulcer. So you can do scoping to check out where the ulcer is. If there's associated cough and spitting out blood, then you can consider pneumonia. You can use an X-ray to assess that. And if there's, okay, shortness of breath and tachycardia, that would be associated with an embolus. Now you're gonna have to give immediate treatment for this because this is emergency pulmonary embolus. If I'm not mistaken, you give heparin? No. I'm sorry. What do you give for pulmonary embolus? Pulmonary embolus. I don't want to like get you guys confused because of my mental gymnastics. Let's see. Pulmonary embolus. 163. Okay, enoxaparin. It's kind of like heparin. but it's enoxaparin. It's like they're both parents. In Filipino, the word for still, well, it's roughly translated to still, like I feel it still, or it's still there, is parin. So, enoxaparins like heparin, parin. That sucks. You can forget that. You can forget that I said that. Okay. But yeah. Yeah. Low molecular weight heparin is different from enoxaparin, but these can both like be used to manage pulmonary embolism. Okay. Now, so the initial test for chest pain is always an EKG. Then after doing the EKG, you're going to also check the cardiac enzymes. So like I said earlier, you're going to check the myoglobin is technically not an enzyme, it's a heart molecule technically. But you're going to check the myoglobin, which it would have gone up in the first hour or so. But you also have to check the CKMB and the troponin levels. And then after doing that, you're going to be doing, well, you already did your cardiac exam, physical exam, EKG, and then the molecules. Now, if your EKG is normal, then you can proceed to checking out, hey, is the patient capable of doing exercise? If the patient can tolerate exercise, then you're going to give exercise thallium. If the patient cannot tolerate exercise, then you're going to give dipyridamole thallium. Is that right? Yes. Yes. Or dobutamine. And then you're going to check the patient. If the patient is able to uptake dipyridamole or the dobutamine causes pain, sudden heart pain. Because what dobutamine does is it increases myocardial oxygen demand, which essentially means it makes the heart feel overworked. And when the heart feels overworked, you're going to feel tired. Now, if the heart already has ischemic tissue, and then this is by chance not detected on EKG, and then you do the dobutamine, if the heart has ischemic tissue, then it's going to feel pain. Whereas if like normal humans, I should not say that. So, I mean, people with normal hearts, there we go. Humans with normal hearts are not going to feel the pain as bad um, in dobutamine. Okay. That's why it's called the stress test, because you're going to make the patient feel stressed. And then the stress is going to trigger similar symptoms. Okay. And then here are contraindications for dobutamine. What are contraindications? The patient has pre-existing arrhythmia. The patient has left ventricular outflow obstruction. The patient has cocaine-induced uh, cocaine-induced chest pain. And then what's the other one? The patient is using beta blockers because the patient can't take beta blockers because beta blockers slow down heart rate. Now, if your heart rate is slowed down, but your oxygen demand of your heart tissue is high, then the slow heart rate is not going to be able to supply that increased oxygen demand of heart tissue, and you're going to cause further damage. So that's why it's those two don't mix well together. Okay. What else? Nuclear isotope, exercise, okay. Oh, something was interesting. You can also give dobutamine instead of dipyridamole, right? Well, I I can associate those two with each other because amine an amine is present in pyrimidines. So I don't know, that amine is like an important component, I guess. Okay. Oh, okay. Next, cardiac angiography. Okay, if the patient is positive on either the stress test, the dipyridamole test, or the patient already has an abnormal EKG, or EKG? No, if the patient has abnormal enzymes, then you can subject the patient to angiography, coronary angiography. Why do you do that? You have to assess which of those coronary vessels is obstructed, because you can't do interventional therapy. You can't surgically repair the damaged or the stenotic artery if you don't know which artery is damaged. And so, okay, normally if the patient doesn't have a history of diabetes, if the patient has only one or two arteries that are occluded, then you can just manage the patient with medications, and you'll only do um, intervention if the medications don't work in the long run. However, if the patient is non-diabetic but he has three occluded arteries, then you have to do immediate and is it PCI? Yeah, immediate PCI. However, the patient is diabetic and has even just two occluded arteries, then you can go ahead with PCI. Oh, I'm sorry. Sorry. For the non-diabetic patient who only has one or two occluded arteries, medical therapy, and then if medicine doesn't work, you do angioplasty or PCI. However, if the patient is non-diabetic and has three occluded arteries, or diabetic and has even just two occluded arteries, then you go for a coronary artery bypass graft. Oh, usually when you do a graft, a mammary artery graft will survive for 10 years. It's going to remain patent for 10 years. Whereas saphenous vein graft is only going to remain patent for 5 years. At the end of 10 years, all patients who have received a coronary artery bypass graft will have only 50%. No, only 50% of patients will have a patent graft after 10 years. Okay. Okay, usually for chest pain, you're gonna give nitrates. Nitrates are gonna help control the chest pain, but you give different kinds of nitrates for different kinds of chest pain. If the chest pain is acute, then you can give it either orally, sublingually, or transdermally. Is that right? Yes, but if it's chronic, you have to give it either IV or, I'm sorry, I got that wrong. If it's chronic, you give transdermally or orally. If it's acute, you give it either IV, sublingually, or patch. No, transdermal is patch. Paste. Through paste. Oh, that's paste. I have not seen paste yet. I would like to see paste. That would be interesting. What else? Okay, what's the most common effect of statins? Um, Liver failure. Well, not liver failure, but hepatotoxicity. Which kind of liver? It's still liver. Not okay. What happens with statin drugs is they block the release of LDL from the liver, which is good for your bloodstream. But the liver itself is overloaded because it's like filling up with all these LDLs, and so that's what's going to cause the hepatotoxicity. Liver dysfunction. I'm sorry. Yeah, liver failure, technically. Now, there's another medication that people give, not statins. What's the other one? Fibrates. These cause myocarditis. Is that right? Yes, myositis, not myocarditis. Myositis. There's a vitamin called niacin, B3, because 3 is a nice number. This is used to increase HDL, and while HDL is the good fat, It has no known, how do you say this? The effect is not significant on patients who have who have coronary artery disease, and it can also cause itching actually if you take too much niacin. And so you can give niacin, but your main to-go medication is your statin. And then you can also give PCSK9 inhibitors. These are antibodies like atenolimumab. Um, what these do is these block PSCK9, and what PSCK9 does is it degrades LDL receptors. So by degrading LDL receptors, no, by blocking the degraders of the LDL receptors, well, you have an increased amount of LDL receptors, and you're going to have an increased uptake of LDL. And so the liver is going to get all the LDL from your bloodstream, so less LDL in your bloodstream, safer heart. Is that right? Yes. They don't lower mortality, unfortunately, but they just help with getting rid of LDL. You don't give calcium channel blockers. You only give these in the rare event that a patient has Prinzmetal angina or other meds don't work. There are other causes for it. What are the other causes? I'm sorry, the cocaine inhibitors are a contraindication for calcium channel blockers. For dobutamine, it's hypertension, not cocaine use. I'm sorry. Calcium channel blockers, it's cocaine induced chest pain, inability to use maximum medical therapy. So use of the typical meds doesn't work. If the patient has Prinzmetal angina and the patient's using beta blockers. If the patient has asthma and beta blockers. Okay. Calcium channel blockers can cause edema. Why? Because by blocking calcium, the calcium stays out of the cell. And I know that if the calcium is out of the cell, then it also affects the flow of water. Because water is attracted to ions. We're more familiar with sodium, but I know that water is also attracted to calcium somehow, and so it's going to cause um, or if it's not the calcium itself, it's the membrane potential, I guess, can also cause that shift. Constipation. Verapamil is a calcium channel blocker, and it most often causes constipation. Okay, if calcium channels don't work, you can also give ranolazine, which is a sodium channel blocker, although it doesn't seem to have any added benefit other than helping with the angina, with the chest pain. Okay, now I am at the part about acute coronary syndrome. What time is it? Oh my, it's 1 o'clock a.m. in the Philippines. Although it's still Valentine's Day in the United States. Happy Valentine's Day to everyone. Me, I am on a lovely date with my book, Master the Boards. We've been together for the past 1.5 months, and our relationship is going strong. But she's just angry at me because I don't spend all the time with her, but I make up for it by giving her all these colorful jewelry. Ugh, that is so shallow. I am so sorry. Ugh, it's all this studying. Okay, next. Um. Mhm. So yeah, we do the EKG. We check if the EKG is normal, check for the biomarkers. Now, if the patient expresses biomarkers with a normal EKG, then you can more or less say that it's unstable angina. However, the patient does not express biomarkers with a normal EKG, then no heart disease. Oh, I'm sorry. No biomarkers makes it unstable angina. Biomarkers makes it STEMI, non-STEMI. Let's start that from the top. EKG, yes, there's ST elevation. Okay, it's a STEMI. No normal EKG, but positive biomarkers, non-STEMI. Negative biomarkers, it's an unstable angina. It's all in the STEMI. STEMI. From the definition of the word ST elevated, you could determine that it's ST elevated by looking at the EKG itself. Then you're gonna see, well, ST elevation, therefore it's gonna be ST elevated. But if there's no ST elevation in the EKG, normal EKG, but the patient expresses biomarkers, then it's a non-STEMI, non-ST elevated myocardial infarction. But if normal EKG, no biomarkers, then it's unstable angina. Okay, I think I got that right after the second time. Okay, what's important to note is that when you are managing a patient with acute coronary syndrome, you always give these 3 meds: aspirin, beta blockers, and ACE inhibitors. You will give those in every case of a patient with acute coronary syndrome. However, of those 3, aspirin is your most... Oh, I am sorry. Not nitrates, not ACE inhibitors. You give nitrates. Aspirin, beta blockers, and nitrates. But of the 3 of those, the most important is aspirin. That's going to help decrease your mortality rate. Okay. Oh, also, when you're looking at your biomarkers, by the way, you should check for renal insufficiency, because you can think that, oh, the patient has increased elevated biomarkers, but it's just because the kidney isn't filtering properly. And so if the kidney isn't filtering properly, you're going to have an abnormally increased level of biomarkers. So you're going to have to adjust for renal impairment before you can use, before you can be 100% certain that they're elevated in renal patients. Okay. Now, in the first few days after myocardial infarction, your worst fear is ventricular arrhythmia. And so that's why patients, after being managed for acute coronary syndrome, they have to be observed in the ICU for a few days before they're discharged, because they can look normal, they can have like all the, no symptoms, and then suddenly they're going to be a they're going to have ventricular arrhythmias, which is the most common cause of mortality. That's why you need to observe for that. Yeah, ventricular fibrillation is a kind of ventricular arrhythmia. Okay. So when you're managing, okay, there's my C word. It's clopidogrel. When you're managing acute STEMI, as always, you're gonna give ACE inhibitors, and you're always gonna give clopidogrel. No, I'm sorry. In acute STEMI, you're always gonna give aspirin, and you're always gonna give clopidogrel. You can't give aspirin if aspirin is contraindicated. Of course, you don't give any med if the med is contraindicated. Now, if the aspirin is contraindicated, you can give instead prasugrel. However, prasugrel is associated with a side effect that I cannot recall at the moment: stroke. So you can't give prasugrel if the patient has a history of intracranial bleeding of any kind, if the patient had history of stroke, particularly non-hemorrhagic stroke in the past 6 months. If the patient is above the age of 75, or there's one more. Right. No, I said it. And then if the patient can't take aspirin and prasugrel, you can give ticlitopine, which has a risk of neutropenia and TTP. T is thrombocytopenic purpura. What does that first T stand for? I forget. Okay, so if a patient comes into the emergency department with chest pain, you're always gonna give antiplatelets, thrombolytics. I'm sorry, not antiplatelets, thrombolytics. There's a difference. However, you would ideally want to do percutaneous coronary intervention. This being given within a 90-minute period of the onset of your episode of chest pain decreases mortality to less than 5%. However, giving thrombolytics alone only decreases it to 30 or 40%. Now, if the patient comes into the hospital, you give them thrombolytics, but there is no facility to do PCI in that hospital. It doesn't make sense to transport the patient to another hospital because then you're going to waste precious time. Because then, right, you have a 90-minute period. So it would be better to just manage with thrombolytics in that case. Now, PCI, by the way, it depends on what kind of stent. If you use a drug-eluting stent, meaning that the stent is laced with a medication that prevents reformation of the clot, then the risk is decreased to 5%. However, if it's a normal metal stent, then it's just decreased to 10 to 15%. Yeah. Okay, you can't give thrombolytics. Now let's look at thrombolytics. I get this one confused with prasugrel. Okay, let's look at thrombolytics. Thrombolytics are contraindicated if the patient has a recent surgery within the past 6 months, if the patient has severe gastrointestinal bleeding, melena, or intracranial bleeding, or if the patient had a history of non-hemorrhagic stroke within the last 6 months. I got that confused also. Recent surgery within the last 2 weeks, non-thrombolytic, non-hemorrhagic stroke within the last 6 months, or a recent episode of melena, or stroke, or hemorrhagic stroke, or intracranial bleeding of any sort. Or if the patient is severely hypertensive, so any blood pressure higher than 180 over 110. Okay. Right. Okay. So when do you give heparin? You give heparin in myocardial infarction, not in stable angina, myocardial infarction. In STEMI, ST elevated myocardial infarction, you give this after PCI, only after PCI. But in NSTEMI or unstable angina, you can give it. You can just give it. Thrombolytics. Thrombolytics, like I said earlier, they only have a lesser benefit. compared to PCI. Likewise, in stable angina, you don't, in stable angina, you don't give antiplatelets. Whew. Actually, it's already 1:20 a.m. and I have not had my coffee yet. Well, of course, because it's like super late at night. But I really want coffee. There are these times like these that I really want coffee. I want coffee. Okay, oh, this is important. Complications of myocardial infarction. Um, okay, especially if there's damage to the blood vessels supplying the AV node, then your patient can be prone to bradycardia. No. The SA node. The patient is prone to sinus bradycardia. The patient, if there's damage to the AV node, the patient is prone to third degree block. Third degree block is when there's no association between the atrial and the ventricular rhythms. It's like all over the place. SA, sinus arrhythmia. No, sinus bradycardia is when there's like a delay in the association. Yeah, when there's a delay in the pulse. Now, if the patient is bradycardic, you can give the patient atropine. And if atropine doesn't work, you give a pacemaker. I think the recurring theme here is you do medical management first as much as possible. But if medical management is not going to cut it, then you have to intervene. So um, for example, when you manage a patient with coronary artery block, 3 arteries blocked, and then no medication is going to help the patient in time for them to get a benefit. And that's why you have to do the CABG right away. Here they call it cabbage. I'm not sure. Do you guys call it cabbage in the States? In other countries? Do you call it cabbage? Calling it cabbage makes me hungry, actually. It makes me hungry. Okay, other complications can include right ventricular infarction. They can include tamponade, cardiac tamponade, and they can also include ventricular tachycardia or fibrillation. No. Ventricular tachycardia and fibrillation are two separate monsters, but they're both kinds of ventricular arrhythmia. Then they're also prone to valve rupture or septal rupture. So how do these present? Okay, there's like a table here. It's very high yield. If a patient has bradycardia with Canon A waves, I think it's sinus bradycardia. Oh, no. It's a third degree AV block. But if there are no A waves, then it's sinus bradycardia. Yes. If there's a loss of pulse and there's distension, jugular venous distension, heart failure, systolic regurgitation. No. Loss of pulse and JV distension. Oh, really? Okay. There's a cardiac tamponade. Next. Inferior wall myocardial infarction. In the history, clear lungs, tachycardia, and hypotension. Right heart failure. RV infarction. Close enough. RV, right ventricular infarction. Why? Because the blood isn't being pumped into the lungs, and so the lungs sound really nice, really pristine. They're untouched, but it's a false alarm because like all the fluid is collecting before the lungs. So right ventricular dysfunction. If there is a new murmur and rouse and congestion, That's valve rupture. Yes, that's valve rupture. Then if there is an increase in oxygen saturation in the right ventricle, because normally you have deoxygenated blood coming into the right atrium. So it doesn't do any oxygen exchange before entering the right ventricle unless there's a break. And how is it going to break? If there's a septal rupture, because oxygenated blood from the left heart is going to flow into the right heart, and it's going to mix, and it's going to cause a slight increase in the oxygenation of the right ventricular blood. Then, if there is a loss of pulse, and the need to use EKG to answer the question, aortic dissection. No, you use X-ray to assess that. Cardiac tamponade. Oh no, that's ventricular fibrillation. Ventricular fibrillation is when it shakes too fast that it doesn't end up pumping anything, and that's why there's a loss of pulse. Man, actually, there was a high yield part here. There was a very high yield discussion here on issues of the birds and the bees post-infarction. Actually, it's quite appropriate that it's Valentine's, but it's inappropriate because, well, my channel is set to be friendly for kids, so I don't think I can really discuss this. Well, there's some parts here that I can discuss, I guess. You never combine nitrates in a patient if the patient is using sildenafil. Otherwise, the patient is going to have incontinence. No. Dysfunction. If it's a male dysfunction. Oh, no. I'm sorry. Male dysfunction is most commonly caused by anxiety. Combining nitrates with sildenafil can cause hypotension. So, you never combine nitrates with sildenafil. If a medication is going to cause erectile male dysfunction, I'm going to have to bleep that, then it's a beta blocker. Beta blockers. Then okay, 2 to 4 weeks after after an episode of an acute coronary syndrome, the patient asks if he can do exercise. You're gonna have to tell them you have to wait for 2 to 4 weeks. Then you're gonna do the stress test again. If the stress test is normal, then the patient can do exercise. Okay, and well, that was it for today. Wow, my video was like 3 hours and 28 minutes, more or less. 3 hours and 4 minutes. 3 hours and 5 minutes. So, I hope you guys enjoyed this session today. I discussed cardiology, and a big chunk of cardiology at that. If you like this video, please don't forget to hit the like button. Also hit subscribe and hit the bell if you're on YouTube, so you can stay tuned for future updates. Before we end, it's time for our word of the day. And until next time, guys, this has been Juan. Remember to always live life to the fullest because you only have one life to live.